Good evening, respected doctors. My name is Ramanuja, Zonal Sales Manager from MSN Labs, Hyderabad. So I welcome all the master faculties and guest doctors for today's evening session on management of pulmonary hypertension and fibrosis in COVID-19 patients. So before we start today's evening session, so please allow me to introduce a brief about MSN Laboratories. So innovation resonates a sense of purpose in the evolution and existence of human life. The creative capacity of a human mind has always been the source of inspiration. We believe every life matters and everyone deserves quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human lives. We are MSN Research for Better Medicine. The quest for innovation drives us to serve better and better today and tomorrow. And MSN has got one of the Asia's largest integrated pharmaceutical API and formulations R&D center. And meet the global Indian pharmaceutical company. MSN has got global presence, turnover crossing more than $600 million US, presence in 65 countries globally and 8 offices worldwide, including US and UK, and 11,000 workforce globally. MSN has won the trust of more than 4 crore customers across 65 countries. MSN has an integrated state-of-the-art R&D center and 14 manufacturing facilities in India and USA, making Tricolor proud. Research for Better Medicine. And MSN's Indian spirit making Tricolor proud. MSN has got 250 plus products in pipeline and 600 plus patents globally. And MSN has filed 715 drug master filings in US market, which is largest in the world. And MSN has got 45 dossiers submitted in other major markets like Europe, Canada, and Australia. MSN has already filed 100 plus abbreviated new drug applications submitted in US market. MSN's 25 products have already approved in US and 20 products are in pipeline for approval and 17 products commercially launched in US market. And MSN's first time in India launches are in 2013, MSN has launched Prasugrel, Febuxostat, Tapentadol, and Tolvaptan. In 2015, MSN has launched Bosentan, Dexlansoprazole, Roflumilast, and Vilazodone. And 2016, MSN has launched Lurasidone. And 2017, we have launched Ambrisentan, Almotriptan, Sildosin, Azilsartan, Mirabegron, Macitentan, and Riociguat. In 2020, MSN has launched Train Time. And now in 2021, we have launched Dapagliflozin, that is Dapa1, Sacutan, that is Sacubital Valsartan, Tofacitinib with the brand name of Tofados, and Brevanest. And MSN's PH innovation, as you all know, Dr. MSN has already established our presence in pulmonary hypertension range. We have launched Bosentan in 2019 and 2012 we have launched Tadalafil, that is PDE5 inhibitor, and Ambrisentan with the brand name of Pulmonex. And 2013 we have launched Sildenafil citrate with the brand name of PAH. And 2017 we have launched a combination of Ambrisentan plus Tadalafil, that is Pulmonex kit. And in 2018 we have launched Macitentan, that is Macitent, and Riociguat, first approved treatment in CTE, PH and PAH, that is Rioc. And MSN would like to partner in practice. MSN's expertise of research to innovate brought first time in India launches to support super specialists in bringing down Indian patient sufferings. Who to better stand by you? A company with global research, global manufacturing, and global quality. Company which has acquired trust globally. We at MSN on a journey to serve you better and better. To partner in creating awareness in the management of pulmonary hypertension and fibrosis in COVID-19 patients, approach for emerging treatment options that to increase the patient's life expectancy and quality of life. So to moderate today's session, we have Professor Jimmy George. Professor Jimmy George is a senior consultant and interventional cardiologist in Lisie Hospital Kochi, Kerala. And Dr. Jimmy George is an ex-executive committee member in Cardiological Society of India, CSI Kerala chapter, and present he is the secretary for Cochin Cardiology Forum and Cardiovascular Research Society, and he is a member in Lisie Research Committee. In 2021, he was invited and attended as a faculty for TCT Asia Pacific CO, Euro PCR, Paris Complex PCI CO. So as an expert and super specialist in interventional cardiology, I request Professor Jimmy George to take over the session from now. Thank you so much, sir.
Thank you, Ramanuja. Thank you for the nice words.
Thank you.
At the outset, I would like to thank the MSN for giving me an opportunity and at the same time taking a right topic at the right time, that is basically managing pulmonary hypertension and fibrosis in COVID patients. Because as we have encountered the second wave of COVID and we are battling for life and not sure whether more waves would come up in the next year or not, it's a right topic to be evaluated and detailed explained by not only from the cardiologic side view, but also by a pulmonology side also. So we have got two eminent speakers for today. I would like to introduce the first speaker. Can I have the next slide, please? The first speaker is Dr. Jabir Abdullakutty, who is a senior consultant cardiologist, at the same time director of clinical research at my own institute, my own senior over there in Lisie Heart Institute, Lisie Hospital Kochi. He has got more than 20 years of experience and he's a CSI National Executive Committee member. At the same time, he has got articles not only international level but also in international level, followed with an excellent track of managing complex diseases and also managing pulmonary hypertension. There are a lot of things for his credit. I'm not going in detail about it, but at the same time, I would say he's a wonderful clinician who manages his patients quite well, and I think he's going to show some exclusively good clinical cases in pulmonary hypertension. Our next speaker is, can I have the next slide, please? Is Dr. K. Venugopal. He's the Chief Consultant and HOD of Respiratory Medicine at Alappuzha Government General Hospital. A well-versed pulmonologist in Central Kerala. He is presently the Secretary of the Heart Attack Prevention Society and the founder and the president of Alappuzha Respiratory Society. And to his credit, he has got more than 33 national publications and has attended a vast number of international conferences. So from the pulmonologist view about pulmonary fibrosis in COVID patients, welcome sir for this meeting. Along with these two speakers, we have got two eminent panelists also. The first panelist is none other than my close friend, Dr. Anil Balachandran, who is an interventional cardiologist and director at the Cath lab at the Lakshmi group of hospitals, also the consultant at Cochin Trust and other hospitals, Aligned hospitals. He is an executive committee member of the Indian College of Cardiology and Echocardiography Kerala. And he is also the CSI executive committee member of Kerala chapter 2021. Welcome, Dr. Anil Balachandran, to this program. Our second panelist is Dr. Sajan Ahmad, who is the Associate Professor and Consultant Interventional Cardiologist at Pushpagiri Medical College, Thiruvalla. He is the Editor-in-Chief of the Kerala Journal of Cardiology from 2018 onwards, and also the editor for the Indian Academy of Echocardiography. He has got a lot of research papers in his credit, and I think it would be a great thing to have both these panelists who would discuss about pulmonary hypertension from the cardiologic point also, at the same time, the pulmonological view also. So, as you know that in this COVID era, we have pulmonary hypertension coming from both because of the COVID-induced pulmonary fibrosis on one side causing RV dysfunction. At the same time, thrombus or embolism formation from the cardiological perspective also causing RV dysfunction. So are we getting PH patients getting more succumb to COVID, or post-COVID, are we getting more pulmonary hypertension? This is something which is bad for the medical fraternity and something which really needs to be thought about. So I invite my first speaker, Dr. Jabir Abdullakutty. Over to Jabir sir for your expert talk on pulmonary hypertension in COVID era.
Thank you, Jimmy. It's a pleasure to be here with you people, Jimmy, Dr. Anil, Dr. Sajan, as well as Dr. Venugopal from Alappuzha, who is the pulmonologist who is dealing with the pulmonary part of the session. So next 15 minutes or maybe perhaps 20 minutes, I'll be dealing with the cardiac part of pulmonary hypertension during the COVID time. It's an extremely, as Jimmy was telling, it's an extremely important topic because we may be seeing patients with pulmonary hypertension who develop COVID, or those patients who develop COVID developing pulmonary hypertension. So we have two problems: care of the patients with pulmonary arterial hypertension during the coronavirus pandemic. And the second is the acute pulmonary hypertension and short-term outcomes in the severe COVID-19 patients needing intensive care. So we have plenty of articles now coming up around about the COVID-19 and pulmonary hypertension regarding especially a new entity known as the acute pulmonary hypertension due to the COVID. And now it is it has been shown that large number of COVID-19 patients may become predisposed to pulmonary arterial hypertension. That for the short time, and what is the prognosis? How we can manage these patients are all new things that we are coming across. I'll show you 2-3 cases to start with. So 32 years old female, she had recurrent abortions, COVID positive 3 weeks ago, antigen negative 1 week ago, progressive dyspnea for one week. She actually, in fact, got admitted today morning in our ICU. Heart rate 94 per minute, blood pressure 110/80 millimeters of mercury, normal heart sounds, no murmur. Right lung venous Doppler, there was DVT. And the electrocardiogram, you can see sinus rhythm. The heart rate is close to 100 with a T inversion in V1 to V5. And with in this clinical context, we may consider this as a RV strain pattern. And the transthoracic echocardiogram, I think you all are able to watch the transthoracic echocardiogram where the RA is enlarged, the right ventricle is enlarged. There is a huge trunk of thrombus in the right atrium, which is in fact moving like a right atrial myxoma across the tricuspid valve. And this patient had recurrent, likely recurrent episodes of pulmonary embolism that has produced her pulmonary hypertension. She has a PAH with a pulmonary artery systolic pressure of around 47 millimeters of mercury. And second case is a 53 years old gentleman, progressive dyspnea on exertion, 3 weeks, heart rate 86 per minute, blood pressure 110/80. The jugular venous pressure was normal. Cardiovascular system examination, there was nothing specific. ECG sinus tachycardia, X-ray test, the PA was normal. The RT-PCR was negative. The COVID antibody titer was high. He was never not vaccinated before. Here, what we can see in the echocardiogram is you can see the mass in the right atrium, mass in the left atrium. You can see the mobile mass, which is really scary. The right atrial mass is prolapsing across the tricuspid valve into almost at the RV outflow tract. And in the left atrium also, there is a mass which seems to be attached to the interatrial septum. So why should there be two things in the right atrium and the left atrium? We did a transthoracic, transesophageal echocardiogram. This also a recent patient, this transesophageal echocardiogram was done 2 days ago. This you can see the thrombus in the right atrium. A huge chunk of thrombus in the right atrium is migrating across the patent foramen ovale into the left atrium. At the same time, a bubble contrast introduced. It is now filling the entire, it is now blocking the entire foramen ovale so that not a single contrast can go across the foramen ovale into the left atrium. And she got operated on 4th June 2021. And this is the finding in the cardiothoracic surgery. They opened up the RA, removed the thrombus from the right atrium. They dilated the foramen ovale a little bit, then pulled out the thrombus. You can see the thrombus being pulled out from the right atrium and the left atrium, and see the huge chunk of thrombus. And this patient who had pulmonary embolism, extensive pulmonary embolism also, and they opened up the pulmonary artery and removed some of the thrombus from the pulmonary artery. So these are the two patients whom I come across recently in the last 2 weeks with extensive thrombus in the atrium. Though we have been seeing DVT and the venous thromboembolism, we seldom see such huge thrombus in the right atrium, which is especially going across the foramen ovale into the left atrium. I'm sure that many of you might also have seen it in the recent time. The third case is a 54 years old female, progressive dyspnea on exertion since 2 years, now in class 4, exertional syncope 3, months, orthopnea 1 month, pedal edema and abdominal distension 1 month, loss of appetite and vomiting for 1 week, and extreme fatigue 1 week. She had a pulse of 94 per minute, regular low volume, a blood pressure of 100/80 millimeters of mercury, parasternal heave, white fixed split second heart sound, RVS3, loud P2, a pansystolic murmur at tricuspid area, and an enlarged liver which is pulsatile. And you can see one recent the clinical finding which was so interesting was her JVP is not well visible on the right side, and on the left side you can see the massive elevation of the JVP with a prominent A wave and a V wave. X-ray chest, cardiomegaly, enlarged right atrium, PA prominent, no pulmonary venous hypertension, and the ECG showing a QR pattern in V1 with right axis deviation suggestive of a suprasystemic PAH. The echocardiogram showing enlarged right ventricle, right atrium, seems to have RV systolic dysfunction, huge pulmonary arteries, pulmonary artery hypertension, and along with that there is a pericardial effusion also. The NT-proBNP was 1700, RA pressure 16, PA mean 54 millimeters of mercury. This is the Cath finding. The PA diastolic pressure 31, LA mean pressure 12, mixed venous oxygen saturation 56%, and cardiac output 1.8 liters per minute. So when we look at the pathological mechanisms underlying the vascular changes in pulmonary hypertension, there is pulmonary vasoconstriction, cell proliferation and apoptosis, inflammation, angiogenesis, thrombosis, metabolic changes. These are all important in this current era of COVID, especially the inflammation, thrombosis, and vasoconstriction. Hypoxia-induced vasoconstriction, the cytokine-induced inflammation, and the thrombogenicity all contribute to the development of pulmonary hypertension in patients with COVID. And those patients with a pre-existing pulmonary hypertension, it can exacerbate the pulmonary hypertension and precipitates a right ventricular failure. So increased pulmonary vascular resistance lead to an increased pulmonary artery pressure with an increased RV or afterload. RV initially compensates from the increased afterload, later on resulting in RV dilatation, and later on the RV fails. And this elevated pulmonary artery pressure constitutes a major determinant of patient symptoms and survival. So the goals of therapy includes reduction in the pulmonary vasoconstriction to unload the right ventricle and to improve the RV function. There are 3 pathways which are involved in the pathogenesis of pulmonary hypertension, and the current therapy of pulmonary hypertension is around management or modulating these 3 pathways. The endothelin pathway, where we use the selective endothelin receptor antagonist, the bosentan, ambrisentan, and macitentan. Our MSN was showing their corporate presentation. They have all the 3 drugs. They have bosentan, they have ambrisentan, and they have macitentan. And the nitric oxide pathway, which is modulated by either giving a phosphodiesterase 5 inhibitor, sildenafil, or a tadalafil, or the new drug, the soluble guanylyl cyclase stimulator. We have the Govt. And the third is the prostacyclin pathway, where we have either the intravenous, subcutaneous, or oral prostacyclin analogs, or the non-prostanoid prostacyclin receptor agonist, that is the Silaxipac. So these drugs constitute the current armamentarium of our pulmonary hypertension therapy. The most important thing in the management of pulmonary hypertension, once we see a case of pulmonary hypertension, especially the chronic PAH, is the risk assessment, where we use these 5 things: the biochemical markers, NT-proBNP, clinical assessment, 4 parameters: the functional class, history of syncope, rapid progression of symptoms, and signs of right ventricular failure. Exercise test, the cardiopulmonary exercise test, many of us are not doing, but the 6-minute walk test is walking distance is something that we can regularly do. We are doing it in our institution. Echocardiographic evaluation, all patients with pulmonary hypertension undergoes echo evaluation. We look at the RA area and the pericardial, whether there is a pericardial effusion or not. Presence of a pericardial effusion in the presence of severe pulmonary hypertension is a poor prognostic factor or a high risk factor. And the hemodynamic evaluation, the 3 important things are cardiac index, right atrial pressure, and mixed venous oxygen saturation. So we have the reveal registry and the friend registry data. And the reveal registry, that it's a scoring system. The friend registry, if we have a score system like this, a functional class is only 1 to 2, 6 minutes walking distance is more than 440 meters, right atrial pressure less than 8, and a cardiac index of more than 2.5. If we have 3 out of these 4 criteria, then it's an excellent prognosis. The long-term transplant-free survival is more than 90% at 3 years. So that's a good prognosis. So if we look into the third case, which I have shown, and risk stratify this patient, we can say this patient has a RA area. You can see the RA area is 33.2. She has pericardial effusion and clinical evidence of RV systolic or RV dysfunction. So if you look at the prognostic factors, if the high risk prognostic factors means the 1-year mortality is more than 10%. So what all things she has? She has clinical signs of RV dysfunction, rapid progression of symptoms, repeated syncope, NT-proBNP higher than 1400, RA area of more than 26, presence of pericardial effusion, RA pressure of more than 14, cardiac index of less than 2, mixed venous oxygen saturation of less than 60%, and a functional class 4. So this patient is at extremely high risk. This stratification is extremely important regarding the prognosis, prognostication, regarding the management outline, and especially during COVID period, when such a patient develops a COVID infection and admitted in a critically ill state, the management differs. I'll be coming to that later. So the treatment algorithm of initial oral combination, once we confirm the pulmonary hypertension, general measures and supportive therapy, look for vasoreactivity. If vasoreactivity is present, that seems to be there in only 10% of patients, they are eligible for calcium channel blocker therapy, pretty high dose of calcium channel blocker. And in non-vasoreactive, in the low or the intermediate risk group, initial oral combination, usually a PDE5 inhibitor, phosphodiesterase 5 inhibitor plus endothelin receptor antagonist. From the ambition trial, we have data with the use of 40 milligram of cadolafil with the ambrisentan. 5 milligram was found to be better than the single therapy. And now the later data shows that from the Seraphin data, it has been found that macitentan may have an edge over ambrisentan in the management of pulmonary hypertension. So if the patient was started on this initial oral combination therapy, then we will reevaluate the patient after 3 to 6 months of treatment. And if the patient's risk status improve, that is the current aim of treatment. Keep the patient in the low risk status for long, and the high and intermediate risk patient may be converted into a low risk status. If the low intermediate risk patient goes back to low risk patient, low risk or maintained in the low risk status, a structured follow-up. If they shift into intermediate or high risk, we may add a triple sequential combination. The triple sequential combination is along with this thing, phosphodiesterase inhibitor, endothelin receptor antagonist, and then a prostacyclin therapy. That is where we all have a problem. We don't have a prostacyclin analog. I have used it only twice, and which was imported, and now it is not available also. The import is also not possible for the use of prostacyclin. And the prostacyclin is the only therapy that has been found, intravenous prostacyclin was the only therapy was found to have some mortality benefit. Then it's a triple sequential combination. And now we are looking forward to the use of selexipag, which may have some impact. And after 3 to 6 months of treatment, again, look at the status of the risk, whether it is intermediate or high risk. If they remain in the high risk or intermediate risk, this is a patient who may be listed for a lung transplantation. And initially high risk, initial combination, it could be a 2-drug combination or even a 3-drug combination, including prostacyclin. If the patient doesn't show any improvement or continue to be in the high risk group after a period of 3 months, this is a patient who should be considered for referral for lung transplantation. So what happens in COVID-19 and pulmonary hypertension? Regarding the treatment of the COVID, there is no non-interaction between remdesivir and dexamethasone with the pulmonary hypertension drug. So the pulmonary hypertension medicines may be continued along with this antiviral therapy. The MABs, there may be some interaction. Continue the pulmonary hypertension medications. Inhaled treprostinil, we are not using it. if somebody because there are people who are carrying it, who are coming from the Europe or America, if they are using it, it may be discontinued and changed to IV therapy, for which we don't have a scope right now. Pulse inhaled nitric oxide may be an option in a sick patient, critically ill patient with pulmonary hypertension. At the end of the discussion, I would like to know from the MSN regarding from where exactly we can get this pulse inhaled nitric oxide. It seems sometimes to bail out some patients. So the issue in pulmonary hypertension and COVID is the pre-existing pulmonary hypertension with COVID-19, the COVID-19 infection who develops a PAH, the pulmonary embolism and new onset PAH. In a pre-existing COVID-19, pre-existing pulmonary hypertension with a COVID-19 infection, when they develop a COVID-19 infection, there are a lot of theories. Is it really protective? Really protective in the sense pulmonary hypertension patients have a down regulation of the ACE2 receptors, and the ACE2 receptors are the portal of entry of the virus into the human body. And when the portal of entry is blocked by reducing the ACE2 receptor concentration, they may be less susceptible or they have some protection against the infection. But at the same time, when the ACE2 is down-regulated, there is increased angiotensin 2 level, because ACE2 is a counter-regulatory pathway for the angiotensin 2. So when the ACE2 is down-regulated, they'll have an increased level of angiotensin 2, which potentiates the lung injury, which is a potent mediator of the lung injury. This high angiotensin level thus can lead to worse lung injury and inflammation if they develop the disease. The immune system also plays a role in the pathogenesis of pulmonary hypertension with increased the perivascular mast cells, macrophages, dendritic cells, T cells, and they could modulate the viral replication or the deleterious cytokine response which is induced by the SARS-CoV-2. Another important hypothetical mechanism is the role of the therapies, the pH targeted therapies, especially the endothelin receptor antagonists, the nitric oxide pathway enhancers, the phosphodiesterase 5 inhibitors, and the soluble guanylyl cyclase stimulators. The endothelin receptor antagonists block the downregulation of the ACE2 by endothelin, and they inhibit the angiotensin 2 induced vasoconstriction and lung injury. So pulmonary hypertension targeted therapies may also have an anti-inflammatory effect as well as an anti-thrombotic effects. And inhaled nitric oxide has been shown to have an antimicrobial effect, but it is unclear whether there are other therapies that increase signaling along the nitric oxide axis have the same effect. And pH therapies, they are vasodilatory. They could worsen the ventilation perfusion mismatch in the COVID-19 lung injury. So we do not know whether it is really protective, whether it facilitates a lung injury due to COVID-19 infection, and is it really detrimental. But one thing is for sure, when a pre-existing pulmonary hypertension patient develops COVID-19 infection, their prognosis is worse than a person without pulmonary hypertension who develop a COVID infection. Respiratory failure, multi-organ dysfunction, septic shock, this all carries a mortality of 45% in patients with pulmonary hypertension. When there is a worsening of pulmonary hypertension in a patient with pre-existing pulmonary hypertension, we have to think of sepsis, progression of disease, ischemia, and right now COVID-19 infection. And COVID-19 infection in pulmonary hypertension leads to more chance of adult respiratory distress syndrome. COVID-19 infection leads to hypoxia, hypoxia-related pulmonary vasoconstriction, acute increase in PA pressure, and it precipitates right ventricular failure. So pre-existing pulmonary hypertension patients without right ventricular failure, if they come with rapidly progressive right ventricular failure, one thing to be looked for is a recent COVID-19 infection. The typical CT findings with a negative RT-PCR, this can be considered as COVID-19 infection if there is a rapid rise in the PA pressure and precipitates right ventricular failure in a patient who had a pulmonary hypertension in the past. So what investigations? The workup requires X-ray chest, CT chest, echo, arterial blood gas, D-dimer. And is venous Doppler mandatory for all patients with pulmonary hypertension admitted in a critical care unit or a intensive care unit? Routine venous Doppler evaluation may not be required, but suspicion of a pulmonary embolism, suspicion of a venous thromboembolism, we may have to resort to a venous Doppler. VQ scan. VQ scan is absolutely contraindicated in the COVID era. It is perfusion scan is okay, but ventilation scan is contraindicated. So VQ scan is not at all a treat or a modality which can be utilized in the evaluation of patient with COVID-19 and pulmonary hypertension. COVID-19 pneumonia and pulmonary hypertension and right ventricular failure, the chance of ARDS seems quite high. We may require high flow oxygen. The chance of aerosolization of virus is high. The viral dissemination chance is high. There are limitations of CPAP and BiPAP. I'm sure that Dr. Venugopal will be discussing these things in detail. And there's a huge question on whether to utilize the invasive ventilation or not. Or if we are using the most aggressive therapies like invasive ventilation, who are the candidates who should be considered for invasive ventilation? So the PAH specific, that's why I spend a little time on PAH specific risk assessment tool to identify patients who are more likely to survive heroic interventions during the COVID-19 outbreak. These are patients with a revealed 2 risk score of less than 9, or those those people who have at least 3 or 4, or at least 2 or 3 of the low risk criteria, invasive or non-invasive, per the French Pulmonary Hypertension Registry risk tool. They have a better prognosis with their pulmonary hypertension, and their current deterioration, the clinical status is likely due to COVID-19 infection. So they should be supported aggressively. And if they can come out of the COVID-19 infection, they may remain in the low risk category and their prognosis may be better. And these are the more suitable candidates for riskier acute interventions during the COVID-19 crisis. I just wanted to impress upon one thing. Every patient of PAH, pulmonary hypertension, are not candidates for a super aggressive therapy, including invasive ventilation, which carries a risk for healthcare workers. So we have to carefully identify the patients who needs invasive ventilation and other heroic measures, and we have to we should not use these measures, heroic measures, in certain group of population where prognosis is already bad. We are not going to save the patient despite all these heroic measures. And at the same time, we are exposing the healthcare workers to the danger of the infection. Acute pulmonary hypertension in COVID. There are multiple mechanisms, of which important things are the concomitant myocardial injury or worsening myocardial injury, the cytokine storm, endothelial injury, hypercoagulability attributing to the development of venous thromboembolism, and the presence of thrombotic microangiopathy. Along with that, there is evidence that there can be pulmonary vascular endotheliitis, thrombosis, and even angiogenesis in COVID-19. So COVID-19 patients, when they develop acute pulmonary hypertension, they have a 7-fold increase of the 21-day mortality compared to those patients without acute pulmonary hypertension. So for those who develop acute pulmonary hypertension, they are at high risk of mortality. Their mortality 7 times, 3 weeks mortality is 7 times than that of the normal person. Diagnostic methods we have discussed: the echo, CT, invasive testing, risk factors, prior PAH, pulmonary embolism, congestive heart failure, COPD. And we have discussed the pathophysiology also, which include the cardiac injury, lung injury, and pulmonary embolism. Their outcome, a lot of problems: ICU stay, mechanical ventilation, ARDS, need for ECMO, and other invasive investigations and management. So management of hospitalized patients with pulmonary hypertension and COVID-19, as you all people are quite aware, hospitalized patient, especially ICU admission with a pulmonary hypertension and COVID-19 infection, it's an extremely sick group of COVID-19 patients. So critically ill, those who are admitted to the ICU, negative pressure room, most of the hospitals are now converting their ICUs for adding the facility of negative pressure. Oxygen, OptiFlow with the patients in N95. COVID-19 treatment as per guidance. Continue the pulmonary hypertension therapies. Do not discontinue. Avoid intubation if possible. Palliative care discussion. If intubation is acceptable, follow standard recommendation of management of PAH in the ICU. Endothelin receptor antagonists can be crushed and given by the nasogastric tube in an intubated patient. Consider transitions of the oral treprostinil and Silaxipag to IV formulation. We don't have those things. and IV prostacyclin has to be continued. We don't have an access to these drugs. Non-critically ill patients, negative pressure room, supplemental oxygen, COVID-19 treatment as per guidance, continue the pulmonary hypertension medications, transition of inhaled PAH therapy to either oral or the IV form, consider nitric oxide as compassionate use. Clinical worsening, he will go into the algorithm of the critically ill patient. An improvement, continue the current management, consider transitioning back to inhaled therapy once documented clearance of coronavirus based on the RT-PCR. No improvement or progression, then consider palliative care or DNR or withdrawal of the care. Discourage CPR. Discourage advanced measures like ECMO support. I think these are the most important things that needs a discussion. The ethical concerns, the most important concern, the exposure of the caring doctors and the supporting staff to the virus. So there are a lot of issues involved in the management of a critically ill pulmonary hypertension patient with COVID-19 infection, especially in the ICU. And this, as mentioned in the editorial which came in circulation, this is a perfect storm. Hospitalized COVID-19 patients and venous thromboembolism. They develop DVT, they develop pulmonary embolism, and of late, what I'm seeing is the huge thrombotic mass in the right atrium and some even crossing into the left atrium. So this is a perfect storm. They can have macrovascular thrombosis, and the first part you can see what is there is they are prone to develop microvascular thrombosis. Major arterial or venous thromboembolism in at least 1/3 of the patients admitted in the ICU. Non-ICU hospital admissions, it is much less, close to 3%. And symptomatic venous thromboembolism, ICU patients, it is 1/3, 27%. Hospitalized non-ICU, it is 2.2. So it means one thing. When the patient is critically ill, that means the viral load is quite high. There is a cytokine storm, there is inflammation. So this is the most important prognostic factor, and this is the one that is leading on to the development of venous thromboembolism. And 31% incidence of thrombotic complications in ICU patients with COVID-19 despite thrombotic prophylaxis. That is one thing that worries us. What should we give to prevent this thing? And 81% of all thrombotic complications and the most common observed in COVID-19 patients are pulmonary embolism. So these patients, when admitted in the ICU, we should be at constant vigil to find out whether there is a venous thromboembolism, and that should be managed aggressively. And who all are prone to develop this? Those with comorbidities, those who are aged, male sex, obesity, cancer, lung injury, cytokine storm. ICU admission, that is the most important. So ICU patients with COVID-19 should be closely monitored for the development of a venous thromboembolism, and those patients with inflammation. And this is the pathogenesis. Inflammatory vascular injury induces thrombin formation, downregulation of fibrinolytic pathways, downregulation of the anticoagulant pathways, the prothrombotic state, platelet activation. One thing that is found in COVID-19 patients is they don't usually develop thrombocytopenia. Initially, people thought this could be a DIC, but later on found that unlikely to be a DIC. DIC, it is more than thrombin. There is bleeding. Bleeding is unlikely in a COVID patient. It is now mostly thrombotic. And the platelet count may be a little elevated, very low chance of developing a thrombocytopenia. So it's a lung injury, inflammation, cytokines, all these things together. There is a crosstalk between inflammation and the immune system, along with the interaction with the coagulation cascade, leads on to extensive thrombosis on the venous side as well as on the arterial side. So how to manage in patients? Daily prothrombin time, APTT, fibrinogen, D-dimer. And the frequency may be reduced depending on acuity and trend in values. Diagnostic imaging studies, if possible, for a clinically suspected DVT or PE. Alternate evaluations if standard imaging studies are not feasible. For outpatients, routine coagulation testing is not required. This is extremely important. Outpatients, low risk category for thromboembolism, and they don't usually develop thrombotic complications. Abnormal coagulation studies used for the prognostic information and the level of the care do not intervene solely based on coagulation abnormalities. Prophylaxis, prophylactic dosing preferred over high dosing in most patients. There are studies going on which is looking at that because 31% of the patients had venous thromboembolism despite thromboprophylaxis. Dose adjustments may be made for increased body weight or a decreased kidney function. Low molecular weight heparin is generally preferred over other anticoagulants. Thromboprophylaxis is generally not continued following discharge with rare exceptions. There are people or there are certain recommendations where we use anticoagulation therapy, oral anticoagulation therapy up to 6 weeks. Many of the major societies across the world are discouraging it, considering the fact that outpatient patients, the outpatients are not at high risk of thromboembolism. Thromboprophylaxis is generally not used in outpatients with rare exceptions. VTE treatment is full dose anticoagulation for a documented VTE or high suspicion for venous thromboembolism. Initiate in hospital as per the standard protocols, continue for 3 months, reserve the fibrinolytic agents for their indication in pulmonary embolism. Clotting in vascular catheters or extracorporeal circuit, full dose anticoagulation, then standard protocols for continuous renal replacement therapy. Bleeding, transfusions for anemia or thrombocytopenia, anticoagulant reversal or discontinuation for anticoagulation associated bleeding. Specific treatment as per indication. Avoid for antifibrinolytic agents in individuals with acute decompensated DIC. So after this, I'm putting forward an array of questions to my panelist and the chairperson, which are the issues I think to be discussed. We don't have an answer. We don't have any guidelines. What is the scope of remote care in patients with pulmonary hypertension in the COVID era? What can we do to give them uninterrupted medicine supply? And certain therapies, we don't have it in our part of the world. Especially, we don't have the prostacyclin. We have to find out what is the way to get into this prostacyclin. Selexipag, Riociguat. I saw the corporate presentation of MSN. They have the Riociguat and the Selexipag, which I think they may be able to supply it as prostacyclin, and nitric oxide. How to get it and use it in our patients who are sick and critically ill. Whether to avoid mechanical ventilation in critically ill COVID-19 patients with pulmonary hypertension, or as I discussed earlier, whether we should selectively use it in a low risk category patient who is going to survive without much issues if they come out of the current COVID-19 infection. What is our concept regarding do not resuscitation order in pulmonary hypertension and COVID? What about the vaccination in pulmonary hypertension patients? I think these patients should be vaccinated at the earliest. And the venous thromboembolism in the face of COVID, whether all the hospitalized patients should be given thromboprophylaxis or only selective patients should be given thromboprophylaxis, and what is the role of thromboprophylaxis in the outpatients. Thank you so much for your patient hearing. And the last slide before signing off, I'll show this for whom the bell tolls. And this is the famous poem where they say, no man is an island, and any man's death diminishes me because I am involved in mankind, and therefore never sent to know for whom the bell tolls, it tolls for thee. So this particular COVID period, in the era of COVID, we have to stand with the mankind. Let's fight this menace. Let's help each other. Let's care everybody. No walls, no boundaries to separate the human minds when the fight is for the survival of the human race. Thank you so much.
Thank you, Jabir sir. Thank you for that extensive presentation, starting with 3 clinical cases, then going up to the treatment pattern and investigation, and finally the etiopathogenesis and what we need to do in this COVID era, and especially the final 8 questions. In the chat box, I got more than 10 questions we got more than 300 delegates who are attending it up. So altogether, it looks like around 20 questions already on. Anyway, so the SARS infection in 2003 onwards, there was a lot of talk or a lot of research on nitric oxide inhalation also. So time reversing the pulmonary hypertension. So that really needs to be taken into this scenario when the COVID infection had come from last year onwards. So anything you like to elaborate on, or anything the Dr. Anil or Dr. Sajan needs to say about it after Jabir sir? You want to say something about, or want to ask about the nitric oxide inhalation also?
Jabir sir, it was a very extensive review of pulmonary artery hypertension and COVID.
And the unfortunate part is that almost 75% of the questions in my mind has been answered already in the slides. But we know that COVID-19 is it's a new scenario for almost all of us. It is evolving over a period of time. And the association of viral infections with pulmonary artery hypertension has very well been documented, starting from the greatest study was done in HIV and HIV associated pulmonary artery hypertension. And in fact, we know from the pathophysiology, as you have very well pointed out, that the pulmonary artery hypertension with COVID-19 is more of a type 3 or type 4 that is associated with lung diseases or extracardiac or thrombotic. And I personally feel that even though we have a good chunk of populations because of pulmonary hypertension secondary to lung injury, but in the long term, I personally feel that there may be a good proportion of patients with chronic thromboembolic pulmonary artery hypertension, because the incidence of pulmonary embolism is found to be very high in COVID patients and also in the post-COVID scenario. So a very good, maybe a proportion of the patients may develop chronic thromboembolic pulmonary artery hypertension in the long term. So that may add on to the total proportion of the pulmonary artery hypertension patients per se. And again, as you very well mentioned, I also went through that article on the physiology of pulmonary artery hypertension patients, and maybe are they immune to COVID-19? That was a very food for thought for almost all of us, because the downregulation of the ACE receptors, as well as the effect of the various pulmonary artery hypertension drugs, whether as a community are they a bit protected against COVID or not, only time will tell. And the most unfortunate part I feel in this part of the country, as you very well mentioned, is that in patients with COVID-19 and acute pulmonary artery hypertension, we don't have much weapons in our armamentarium, because none of the drugs which are found to be effective in the acute pulmonary artery hypertension is available in our scenario. The only thing that we can give is maybe high flow oxygen therapy, or to a certain extent maybe non-invasive as well as invasive ventilation. So that is one shortfall that we have currently in the management of patients with acute pulmonary artery hypertension. And of course, I think Dr. Venugopal said in his next talk, because we see a lot of COVID-19 patients with pneumonia having a very bad lung in the post-COVID phase. And in fact, that can result in a number of patients with severe pulmonary artery hypertension in the long run. So these were my thought process. And in fact, ACC had, the American College of Cardiology had made a separate statement on patients with pulmonary artery hypertension and their treatment as well as follow-up in the COVID-19 period. And they have made special mention, and even there was a Facebook Live by ACC regarding this subject, that is pulmonary artery hypertension and COVID-19. That was very well received one. So this is a topic definitely worth discussing, actually.
Thank you. And Anil, I also feel one thing. Look, we all thought last year at this time, we thought that the COVID, we have conquered COVID. The COVID is going to go away. This year, by this time, we'll be there in some remote island in Malaysia, or in the rainforests of Malaysia or other parts of the Asian or European countries, and enjoying a vacation. But unfortunately, nothing happened. Rather, a second wave come, and we are getting prepared for the third wave. But at the same time, I think the virus is changing. The virus is changing us, our beliefs. The virus has produced change the human philosophy also. I think the virus must change, because that may be the reason why pandemics are coming in succession in particular cycles. And after some centuries or years, a pandemic comes and it teaches the human community, look for survival. You have to live as a herd, and you should forgo or forget your differences and fight. That is how the human race survived. It is fighting spirit, and they live together. We have to fight together, not us fighting separated by boundaries or countries or race or other things or ethnicity. The most important thing what I feel is that now, of late, in 1 month, we are seeing patients more of thrombotic complications. So I think there is a phase. The phase of lung injury, then the sequelae. The sequelae will be a persisting myocardial injury, a persisting lung injury, pulmonary hypertension, thromboembolism. I think cardiologists are going to see this sequelae, and we should be tuned to manage this thing. The only problem is, despite our weapons, this virus-induced injury and thrombosis is very resistant to our thromboprophylaxis or treatment. That is a problem. I don't know how we are going to manage. Probably the cytokines have to be tamed. That is the only way by which we can prevent a thromboembolic episode. I'm sure that Dr. Venugopal will be talking much thing about it. So what can we do? These are the things we can do. As you rightly pointed out, how to get hold of this nitric oxide or prostacyclin. I've been trying hard. I discussed with my colleague, friends in Mumbai. They are telling that now they are also not getting it. And prostacyclin, they used to give 5 lakh rupees per course of treatment. I know it's extremely difficult now. I think MSN at the end should give us how we can get hold on even at least Riociguat or Selexipag. We are not available right now. And I must thank Sajan for some of the references he sent me. I asked, can I get some references? And Sajan sent me some references which were really useful. So how often
Jimmy, can I?
Sajan,
yes, Sajan.
Yeah, just to mention that listening to Jabir sir was like listening to a symposium, right from pathophysiology to the management. It was a very beautiful review. Basically, I think when we think of this COVID and pulmonary hypertension, we have to think in 2 settings. One is somebody with PAH having COVID, and the other is, of course, COVID leading on to pulmonary hypertension. As Dr. Anil mentioned earlier, even though theoretically the ACE2 suppression in PAH will bring down the risk, but real world data, especially from US over multiple centers, has shown that the severity of disease is more, in fact, in patients with pulmonary hypertension. The hospitalization rate is more, requirement for ICU admission is more, and the mortality rate in pulmonary hypertension is more, around 12 to 20%. So that is significant. So we should not think that we should not go away with the message that patients with pulmonary hypertension will do well because they are protected by the ACE. That's a practical reality. The second thing is when somebody has COVID and how does it lead to pulmonary hypertension? Of course, we have to think of 3 components. One is the pulmonary circulation, the lung tissue, and of course the myocardium. So these are 3 pathways. So in the pulmonary circulation, of course, there is vasculopathy and there is coagulopathy. So it is not just the prothrombotic state. There is a vascular involvement also, which was not seen in the earlier SARS virus. So that is one thing. Second is, of course, the lung damage and how it can itself lead to pulmonary hypertension. And thirdly, maybe under-recognized because we are not evaluating properly, because even cardiac MRI studies have shown that to 40% of hospitalized patients have some form of myocardial involvement. So either producing systolic dysfunction or diastolic dysfunction. And this, in fact, left heart disease can also lead on to pulmonary hypertension in the long run. And finally, just one point, when we assess pulmonary hypertension, we should be very careful not to underestimate pulmonary hypertension because of the concomitant presence of RV dysfunction. So when somebody has significant RV dysfunction, we may not get that much of RV systolic pressure elevation, and we may think that there is no it is a primary myocarditis involving the RV rather than a sequelae of significant pulmonary hypertension. That's all. Beautiful description, Jabir sir. And I see that you have virtually gone on to see Aurora Borealis in the background, we can see. And of course, your trademark reference to literature, beautiful as always. Thank you.
Thank you, Sajan. Thank you for the thing. Actually, like we have seen more of dysregulation in the coagulation cascade. Like most of our patients, we used to give aspirin last year. Along with that, even rivaroxaban low dose like NOACs in COVID patients. But now what we see in this era is like a different variant where the thrombosis is so much rampant or so much increased that these anticoagulants or antiplatelets are not enough. And we may have to go for other invasive modalities or surgical modalities to remove these thrombus. And that is what, like cases which Jabir sir just showed, how the clot had to be removed from the chambers of the heart, as well as the thrombus, pulmonary endarterectomy also will be something quite getting more and more for the surgical side in the future when chronic pulmonary thromboembolism could be more evident in the next few years. I think so we can just go to the next talk and then continue this discussion, because Venugopal sir also was saying that he needs to give a talk about fibrosis. So if the panelists don't mind, I think we'll go to Venugopal sir's talk and then we have a discussion. Over to you, sir, for your talk on pulmonary fibrosis in COVID patients or COVID era.
Good evening all. It's giving me intense pleasure to be with you in this Sunday evening with the eminent three eminent cardiologists of the Kerala. And I would like to express my gratitude to MSN Laboratories and Dr. Jamie George for the nice introduction and this opportunity. You have elaborately covered the pulmonary arterial hypertension. At the last May 4th was the Pulmonary Hypertension Day, and we celebrated here also. But COVID infection is mainly a pulmonary infection. So the majority of the patients are from coming in our field, that is pulmonology. But we are going to cover only a part of its complication, that is the fibrotic sequelae, because the topic is only for the fibrosis. So we will cover what are the available information in the now about the fibrosis and its management and diagnosis. So as you all know that the SARS-CoV has created one of the most massive pandemic in modern history. In our life also, that's one of the most devastating disease and most threatening for all the humankind of the world. And the lung fibrosis is an emerging complication of SARS-CoV-2 infections. A brief insight on the pulmonary fibrosis resuming as a consequence of COVID-19 infection will be emphasized in these few minutes. So COVID pandemic, the prevalence in India is just, that is increasing with the second wave. So every day it is on increase. For the last few days, it has got in a standstill or a decline in that trend. Then about the prognosis of COVID, we have seen that many slides on the prognosis, but most importantly with the COVID-19 have a good prognosis. That is a good thing, but the infection rate is very high. So even with a minor degree of or minor percentage of complication can have a huge loss for mankind. But a small portion of the patient become critically ill and even dies. Thus, with the increase in COVID-19 cases, the global health care is anticipated to encounter an increasing burden of the aftermath of the disease. That is 61% of the patient with the COVID-19 present with a mild symptom, that's fever, cough, or upper respiratory tract infection symptoms, or a mild disease. Of the 14% patients have a respiratory distress or hypoxia, which requires admissions that come under category B or C. Among these, 5% will go for a severe disease requiring ICU care and even ventilatory management. So in acute phase of the pandemic, billions of cases of 5% go to a severe or critical symptoms, among which 30 to 50% have complete full recovery, and about 20% go to the death, and 30 to 5% pulmonary fibrosis. So increasing number of patients worldwide who have survived COVID-19 continue to battle the symptoms of the illness major long after they have been clinically tested as negative. They are called low haliers. Various studies have reported among that 70 to 80% patients who recovered from the COVID-19 present with the persistence of at least one or more symptoms even after being declared COVID-free. So I am conducting a study of the post-COVID symptomatology. I have got the data from about the 500 cases, and I have presented the data for the last national cohorts also. So the COVID-19 sequelae may vary from mild fatigue or body ache to severe forms. But few patients without any symptoms also are reporting to our center because of the fear of some of the sequelae. Some requires long-term oxygen therapy and lung transplantation due to lung fibrosis, significant cardiac abnormalities, and stroke leading to significant impairment of cardio health also we have seen in Jabar's class. So the pulmonary fibrosis is one of the sequelae of the COVID-19 pneumonia and account for the mortality in a substantial proportion of these patients. Yearly analysis from the patient with the COVID-19 hospital discharge suggests that at least 1/3 of the recovered patients develop fibrotic abnormalities. And the radiological manifestations such as fibrotic abnormalities of the lung became detectable as early as 3 weeks after the onset of symptom, regardless of the severity of the acute illness. So that is an important factor, that even after 3 weeks of illness, a patient can develop features of fibrosis in CT, which is unlikely seen in many of the well-known older fibrosis diseases like IPF. In fatal cases, COVID-19 organizing diffuse alveolar damage is the pathognomonic hallmark with the pulmonary fibrosis of varying severity. So risk factors for the development of fibrosis are which are also the risk factor for the death is advanced age, illness severity. With the severe illness can have a high risk for the development of the fibrosis. Then being a mental, male, gender, or comorbidities like hypertension or diabetes, which is also a risk for the death. So the mechanical, those going to the mechanical ventilation are at risk of, that is category 3C patients. And the length of the ICST also is a determining factor. Then chronic alcoholic smoking also identified as well. The major risk factors for severe COVID-19 are shared with the idiopathic IPF, namely increasing age, male sex, comorbidities such as hypertension or diabetes. And this is the pathogenesis of the COVID infection, the inflammation and the risk of the start even with the entry of the virus into the cells. With the entry of the cell virus into the cells, there is epithelial and endothelial damage, which can cause cell injury, leading to propagating and initiating an inflammatory response. So during the viremic stages, viral shedding from the infected cells, there can also inflammatory release, and associated inflammation can also occur during the multiplication inside the cells also. So the other type of barotrauma, like during mechanical ventilation, also contribute to the factors for the mechanical precipitating the fibrosis process by precipitating the inflammatory process. The SARS-CoV-2 dependent on binding to the angiotensin converting enzyme, as we know that it through enters to the ACE2 receptors, which is a part of a renin-angiotensin system. So downregulating ACE upon binding disturb downstream activities of renin-angiotensin system, resulting in increased inflammatory development of fibrosis. So this can also activate the macrophages and T cell activation, producing the cytokine storms, and also it can lead to inflammatory edema, leading to pulmonary edema or fibrosis. It activates the fibroblast and the microthelial cells. So the radiological findings of fibrosis include an interstitial thickening. So this interstitial thickening or air consolidated with air bronchogram or irregular interface with a normal and affected part of the lung, then coarse reticular patches or parenchymal bands or even pleural effusions. The coronal view is showing much of the interstitial thickening, and the transverse view also showing this ground glass appearance also with some of the bronchitis changes. The early bronchitis changes can be seen. These are the few studies done on the living patients that the majority of the cases are of having comorbidities. Those who develop pulmonary fibrosis in the later or the 3 months stage. So they also have some respiratory support, put some representation nasal cannula or either mechanical ventilations. So the CT evidence of fibrosis are present in all of these examples. The study conducted on these patients. So going to the diagnosis part, it is again a patient is suspected of ILD, like fibrosis. You have to go for an initial clinical evaluations that include history and physical examination that can be done as video conferencing. And then a CTD serology evaluation is necessary to rule out the other causes for the ILD. So there are, just like the PAH complicating COVID infection, here also two conditions can occur. Those existing IPF can get a COVID infection, and those without any pre-existing interstitial disease can also develop COVID infection and develop to pulmonary fibrosis. So we have to exclude the connective tissue factor diseases to other causes of the interstitial lung disease in these patients. Then just HRCT is indicated because if you suspect of ILD, the best diagnostic method is just HRCT. Then PFT is necessary to evaluate the lung, the physiology of the lung, but it may be deferred because of the chance for the aerosol generation with these investigations. Then a potential cause-associated condition is detected. You can diagnose as a not IPF. But if there is no such evidence is seen for the ILD, then for the just HRCT pattern, it can be a probable interstitial pneumonia pattern or intermediate or alternative analysis, in which you have to conduct a multidisciplinary discussion sections in which you may decide for a PAL. PAL is again a aerosol generative procedure. You have to more careful going for the PAL or a lung biopsy for the confirmation. So after getting this definitive idea about after these discussions, we can get a professional diagnosis up to 89% of patients or unclassified ILD less than 50%. If diagnosed in IPF, you can go for the management parts. The management modalities of management are available. The first one is the antiviral. Antiviral remdesivir is the one proven efficacy can be used because viral multiplication of viral entry itself can aggravate or precipitate or as a starting point of the inflammatory process which can lead to fibrosis. The others available now is the spironolactone. This melanocorticosteroid receptor antagonism is also showing some favoring a response. Then traditional Chinese medicines is again in the on the trial. It is a plasminogen activator. So the definitive treatment now available is the perfenadone and pindizavin, these antifibrotic agents. So management of the perfenadone is the one available drug showing much enhancing results are because of its action on these parts. The potential role of the antifibrotic therapies is suggested based on the substantial evidence of a proposed resolution to the mechanism of the post-COVID lung fibrosis into idiopathic pulmonary fibrosis. So we were using this perfenadone and intervention for the IPF for a long time. So we are extrapolated the beneficial effect of the perfenadone for this fibrosis also. Perfenadone and intervention might extend potential benefit in the prevention and treatment of pulmonary fibrosis following COVID infections. Mode of actions act by multiple mechanisms to mitigate the fibrosis and scarring, inhibiting transforming growth factor beta and thereby slowing the progression of IPF. The perfenadone, which shows effective against inflammation, fibrosis, and oxidation, can attenuate lung injury because of the perfenadone-induced LPF-induced acquired lung injury and subsequent fibrosis. Perfenadone has a downregulating effect on the cytokine as TGF, beta-1 or connective tissue growth factor or platelet-derived growth factor. In addition of being a reactive oxygen-specific radical, a scavenger, and antioxidant, perfenadone can also prevent some of the fibrotic mechanism run through this oxygen radical-induced injury. The other cause of perfenadone that make it appropriate for the treatment is COVID-19 is its anti-apoptotic and anti-fibrotic effect. This can be seen in the picture representation. So these are the inhibitors, but matrix metalloproteins, it is a coagulase enzyme induction. It is a pro-activating factor, but others it is also inhibiting factors. So suggested dosing for the perfenadone is the initial titration is the first 1 to 7 days. You have to start with 260 milligram and PAD, and the maximum dose and slightly increased by 8 to 40 days increased to 534, and by 15 onwards 801 milligram, which is tablet available. In total, come about 2,403 milligram per day. So dose modification maximum, that is the maximum dose. Maintenance is 3 capsules per with food, because it can have some gastric irritation, so better to have the foods. So the dosage modification, if significant adverse effect occurs like GIT, rashes, or photosensitivity reactions, temporary dosage reductions or therapy by interrupted may be considered to allow the symptoms are resolved. Discontinuation therapy if the significant adverse effect persists despite this reduction in the dosage. So in pregnancy, it is not indicated because come under class 3 drugs. Then pediatrics use is also safety and because is not established. Liver disease also to some modification of the dosage is necessary. Therapeutic benefit and outcome is the improve the SpO2 during the 6 minutes walk test and slow the progress of the IPF and to slow decline in the lung function, slow down the lung function and increases 1 to 3 years survival and stabilizing lung functions. Then Ferfunan is safer than Nintedanib because Nintedanib also has an antifibrillary action which can slow the progress of the pulmonary fibrosis disease regardless of the pathological pattern by inhibiting the release of pro-inflammatory and pro-fibrotic mediators, the mitigate difference of the fibrocytic and fibroblast and the deposit of extracellular matrix. However, the Nintedanib is associated with increased risk of bleeding, which is other complication, intracranial and other visceral bleeding is another complication which can precipitate when even Nintedanib is given for a COVID patients with bleeding tendencies. So before 2019, Nintedanib had been studied exclusively for the IPF, and Nintedanib has been found to be effective in treating systemic sclerosis related lung disease and a non-IPF progressive fibrosing ILD. Perphenol has been found beneficial for unclassified ILDs. Whenever there is antifibrillary drugs are effective in treating post-COVID lung fibrosis, also unknown. But theoretically, it has a background of theoretical background for starting this drug for the preventing or as a treatment of the established pulmonary fibrosis following COVID infection. There are no randomized studies that essential role of the peripheral in post-COVID, but one study is now going on. And inhaled formulation of Ferfunan is under evaluation of the patient with the COVID-19. Similarly, another trial of named this Pincer is underway to evaluate the efficacy of the safety of the Ferfunan versus Nintedanib. So the data from the landmark clinical trials such as Impulses and Inbuilt and Ascent studies as favoring that of use of the Perphenadine in the treatment of the pulmonary fibrosis. The efficacy study, that is the study of the Perphenadine efficacy study in idiopathic pulmonary fibrosis. Impulsive trials. This is the trial is started even before starting the COVID pandemic, but it is still continuing. And this is for the IPF. Aim is the 52. So the research is that the rate of change of FEV and rate of change of FEV in trial 1 and 2 both showing a favorable difference of 125 and 97 ml change of decrease in the FEVC. So before, so the Ascent trial is another trial which is showing about 60% only patient showing extensive FEV decline of 10% or more. But for the study group, Perphenadine reduced by 27% of the proportion of the patient who experienced a decline in 6 minutes watts of 50 minutes or greater, and Perphenadine reduced 43% of risk death or disease progressions, and the most common adverse effect with the higher incidence of the Perphenadine group are primarily gastrointestinal and skin related, that is the photosensitivity or mild to moderate severity can occur for. So steroids and spironolactone is also being used as a treatment for the fibrosis. The rationale of the steroid is the use of the corticosteroids in viral pneumonia is to be decreased, and the host environmental response the lung, as this may lead to development of acute lung injury and ARDS. But the use of the steroids now be in cautioned because of the chance for the super infection, especially of the fungal or other opportunistic infections. Although there is no reliable evidence that the efficacy of the corticosteroids in treating pulmonary fibrosis following SARS-CoV infection, they are commonly used as an empirical therapy for the post-inflammatory pulmonary fibrosis, using as an empirical, because many of the studies, the results have yet to come. So, however, the use of the steroids is controversial, as the direct evidence for the use of the corticosteroid is very limited. In the country, the current research says that administered systemic steroids during COVID infections, as they might delay the clearance of viral RNA and cause a decrease in risk secondary infections. Then about the spironolactone, is aldosterones, which is an adrenocortical hormones and a physiological melanocortical receptor activator, is partially responsible for the increased extracellular matrix turnover, which is observed in pulmonary fibrosis, and except its effect primarily on the lung epithelium. There is no direct studies that present the beneficial effect of this melanocortical receptor antagonist in post-viral fibrosis, but it could serve as a potential treatment for such serious lower respiratory tract infections. So, tissue plasminogen activator, in patient with the COVID-19 induced ARDS who have got PO2 FiO2 ratio less than 50 and PO2 more than 60, despite a prone positioning and optimal mechanical ventilator support, appear to be candidate for tissue plasminogen activator, especially in environment where ECMO is not available. In scenario where no further mechanical ventilation is possible, tissue plasminogen activator may be appropriate as a rescue therapy in people with progressive deteriorating lung functions. It is important to remember that thrombocytopenia may occur in patients with COVID-19, which reduces the possibility of using this therapy because the associated combined complications. So other treatment options for the pulmonary fibrosis COVID-19 is in presence of the fibrosis, it is important to reduce the viral load and hence duration for the pneumonia. Amongst the virus, antivirus, hydrochloroquines and remdesivir seems to be the most promising ones. Chloroquine hydrochloride disturb the coronavirus cell receptor glycosylation and modulate the immune systems. The latter proved efficient in vitro activity of SARS-CoV. Remdesivir and leponavir or ritonavir might inhibit RNA replication due to high affinity viral enzymes, reverse transcriptase or protein biosynthesis through premature termination inhibition. So all the steps are inhibited by the various antiviral presently used. Then teicoplanin inhibit the first stage of the coronavirus cycle in human cycles, and lopinavir and ritonavir might be effective against coronavirus if combined with the other interferon at ribavirin, and favipiravir, which is very commonly used now in Kerala, also may have one of the possible treatment options of the COVID-19 has been shown that able to inhibit the virus reproduction in the intracellular system. So the post-COVID is CT scan finding follow-up with or without treatment. So this is one study. The COVID-19 survivors who varied clinical course after the initial recovery. Some patients recover fully with no residual symptoms and no functional impairment. However, some experience persist symptoms or functional impairment after the initial recovery. The COVID symptom study suggests that approximately 10% of patients might still have symptoms after 3 weeks and some even 4 months. The post-COVID sequelae have been responsible for including pulmonary fibrosis, pulmonary and systemic vascular diseases, which can lead to contributions to the pulmonary arterial hypertension, then bronchitis and chronic fatigue syndrome, and mental disorders, that is including the post-traumatic stress disorders and depressions are very common. The data on the short to long-term follow-up of the coronavirus pneumonia surveys is scarce because yet to come many of the study results. The result from a prospective longitudinal Hawker study, the study design was a patient with admitted to hospital severe COVID who died, did not require mechanical ventilation, but prospective followed for 3 months, 6 months, 9 months, and 12 months. So the result of the study is like that. Or 3 months, up to 78% of the patient is having abnormal HRCT at 3 months. At 6 months, these are the patients which is not underwent any of the mechanical ventilation. So at 6 months, 48 patients had abnormal HRCT, and ground glass opacity is the major main findings in the HRCT. In 9 months, 27% had abnormal disease. 9 and 12 months almost similar. Only 20 to 27% are remaining with some of the features of the architectural abnormalities. Then comparison of the patient with severe comorbid and normal versus abnormal chest X-ray. Patient with abnormal radiograph changes in 12 months also increase lung. Those having a high hospital stay or increase peak HRCT prominence, or patient receiving high flow nasal cannula oxygen or NIV, or both were likely to have abnormal HRCT. Significant difference in pulmonary function test parameters also having had. So strategy to reduce potential exposure to COVID-19 patient for fibrotic intestinal diseases seems similar to that of the any man to keep the standard, social standard, so follow the local public health recommendations. And the fibrotic patients may have to get the telephone consultation, and everything is government available by Sanjeevani. Then hygiene practice also have to be followed. Then investigation differ are the very essential infection, and treatment also have to be as far as possible through telephone messages. So take home message from my presentation is consider huge number of individuals affected by COVID-19, even rare complications like post-COVID pulmonary fibrosis will have a major health effect at the population level, and elderly patients who require ICU care and mechanical ventilation are higher as for dermal lung fibrosis. Perfenadone could inhibit apoptosis and downregulate ACE receptor expression and decrease inflammation by several mechanisms and ameliorate oxidative stress, and hence protect pneumocytes and other cells from COVID invasion and cytokine storm simultaneously. There are no randomized studies that have assessed the role of perfenadone and nintedanib in post-COVID fibrosis. However, data from the previous landmark trial potentially suggested that antifibrotic therapy, when used early in SARS-CoV infections, might have major benefit in reducing the fibrotic damage. Evidence of the persistent physiological and radiographic changes when observed in COVID-19 surveys, hence routine respiratory follow-up patient hospitalized with COVID is warranted. Thank you for the patient hearing.
Thank you, Venugopal sir. Thank you for the nice presentation. Frankly speaking, as a cardiologist, I don't have much experience on fibrosis management, but from your experience, sir, I would like to ask, how early would you try to prescribe these antifibrotic medications, and whether these COVID fibrosis, are they reversible if you start early on, and how would you continue these medications for lifelong, these patients, as we may be experiencing more and more waves in the next future also. So what is your comments on that, sir?
Okay, but the long-term follow-up and the requirement of the drug is yet to come because we have only experience of 1 year follow-up for so far. But majority of the cases will are resolved by 3 to 6 months. So usually it have to be followed up to 6 months with these antifibrotic agents. Otherwise, by the serial HRCT, you have to decide whether it will continue lifelong or not. That is all.
And which one of these two things, two antifibrotics, would you give the weightage, or any specifically one for one patient or the other for the other one? Any preferences there?
Preference is again depends on the availability and the patient and the cost and other things. But the perfenadone is almost similar, but perfenadone is preferred over nintedanib because of the few reasons I mentioned.
Okay. Jabir sir, or Dr. Anil and Dr. Sajan, you want to?
I just wanted to ask Dr. Venugopal a question. Or rather my doubt, how often do you see this pulmonary fibrosis in patients with COVID-19 infection, and what is the chance of progression of this into a chronic fibrosing alveolitis or a chronic fibrotic lung disease?
So chance to progress to a chronic lung disease, lifelong lung disease like that of IPF is less. We are seeing only few cases, but that too on ventilated patients. But the invasive ventilated patient recovery is almost nil for in our center, for the Alappuzha and General Hospital. For whoever recovered having some fibrosis, but still few patients are in our control getting this antifibrillary treatment for the last 8 months. That is all.
There are some patients who comes to us in the post-COVID scenario after 3 weeks or 4 weeks. They all have significant breathlessness. We couldn't find anything in the heart. So could it be a fibrosis? I'm not sure. I do not know. But they are significantly symptomatic. They can't even walk for half a kilometer. They can't even climb there. They're on the stairs in their house.
So two things that can occur for this patient is, one is from your side, this is the microembolism. Microembolism can produce some the gaseous exchange problem, and even also can precipitate some pulmonary arterial hypertension. The other is the interstitial edema, which can be very well respond to some steroids. So short course of steroid for these patients is beneficial.
Is there any definite investigation by which we can tell that this person has developed fibrosis? Will CT really help in the early phase?
No, nothing is recommended. They are telling that you have to take a serial HRCT with twice monthly basis.
Oh, that. I don't know whether in the current COVID era, whether our common man will be able to afford all these things.
We have to get information for doing like a research mentality for this kind of patients. That is okay.
Venugopal, it was an excellent presentation. For people like me, this is a path less traveled. I would just like to ask some basic questions. One thing is that is the fibrosis in COVID-19 a bit accelerated compared to the normal idiopathic pulmonary fibrosis? That is point number one. And second, you told there is is there a gender preponderance because males were more commonly predisposing factor for pulmonary fibrosis? And the third part is that does the people with reactive airway disease have more preponderance of fibrosis if they get a COVID pneumonia? And does the initial CT scan score has any correlation with the development of future fibrosis?
Yeah, the first one, the inflammatory response. So there is a dysregulated inflammatory post-COVID system in the all over the body. So all the inflammatory disease are at a higher end for these kind of patients. So that can occur. For the male predominance, it is seen for both IPF and post-COVID fibrosis also. And there is an accelerated response for those predisposed for ILD. There is accelerated response for following COVID infections. That is it. And the other airway disease, there is no much increase with this, because even with the 5 days symptoms, they are recommending for starting of inhaler budesonides. So that may aggravate many of the probable increase of the airway disease for these group. And maybe the reason for we are not getting much an increased incidence of the airway disease following COVID for these kind of patients.
And that's the initial CT score.
Initial CT score is very important for future predicting the fibrosis later on. Those having a high score more than 10 are more prone for development of the fibrosis later.
And the latest one in the block is the addition of the newer anti-rheumatology drug, which is along with remdesivir, which has recently been approved in India. And there was a trial recently with remdesivir with that anti-rheumatology drug, which showed better results in patients with inflammatory syndrome and all. Does that have any effect on the prevention of fibrosis, future fibrosis?
Maybe we are working out the CTD markers for these patients with fibrosis, because the CTD is associated with some fibrosis. So definitely the mechanism, so it's a theoretical background, it may be helpful, but let us see what is the result of the study.
Dr. Jimmy, may I?
Please go ahead, sir.
Yeah, Venugopal sir, thank you for the excellent review, because it's an entirely new area about which we are not very aware. So thank you very much. Just a practical question that I want to ask. When patients come to the OP with exertional breathlessness after a recent COVID, they usually go to a cardiologist or a pulmonologist or a physician. That is what happens. So if they land up, so the initial route of evaluation, in fact, depends upon where the patient is landing first. So if the patient comes to the cardiologist with exertional dyspnea, we will invariably be doing an ECG and an echo. Like Jabir sir said earlier, many of them, even with significant symptoms, we may not find anything positive. And then we will be referring to a physician or a pulmonologist. So clinically, is it, by auscultation, is it can we triage patients to advise them to go for a CT chest, or do you think that most of the time you won't get any auscultatory findings? Just a common question. I know auscultation is not much discussed these days, but still.
Frankly telling, the auscultative findings are scarce for these patients. But patient is always telling there is a clinical symptomatological discorrelation. So what we are getting for the auscultation is almost a normal chest, but getting exception is a very severe exception.
Okay. So the unlike the end respiratory crepitations and all are not usually found.
It is very difficult to
okay.
in the clinic. But the 6-minute walk testing is an alternative for this kind of patient, because in every OP now we have got the pulse oximeter. We can ask the patient for a few minutes walk, and then dip more than 3% is significant, then patient can be sent for the pharma.
Okay, thank you, sir. Thank you.
So what about the pulmonary function test?
In the COVID era, some people previously used to tell that you should not auscultate.
No, this is post-COVID, sir. Post-COVID. I am asking about post-COVID follow-up visit in the OP.
No, some of the doctors have abandoned the use of using stethoscopes, abandoned the method of touching patients. Some of my patients who are coming to the OP, I find it difficult to go to certain doctors that doctors even don't look at you. They are so scared. They consider you as a previous leper or something like that. No, it's a reality, sir. I'm also afraid of it. Are we moving more and more away from the patient? Already we are totally away from the patients. Now I think we will sit in one room and we'll keep the patient in the other room.
That kind of consultation is occurring somewhere. And in our OP, in medical OP, the patient is sitting about 2 meters away. There is a rope in between patients and doctor.
I think when patients also won't find difficult to sit along the chair because they say other patients already sat in the OPD. Some patients are there like that also. So both sides it will be there. Yes. So other than imaging, would pulmonary function tests, which would be more cheaper and more convenient for the patient, if you progressively assess this in the future, will it be of any benefit?
Yeah, PFT is mandatory for diagnosing the IPF or lung fibrosis, because we have to assess the functional efficacy of the lung. So in future, we can turn for the PFT test once it is controlled and all are vaccinated. But again, some of the protocol has to be maintained by doing this test. There is a recommendation from the Indian Chest Society. How can you do the? But there is another in spirometry can be done with a peak flow meter. Minimal type of spirometry can be with a peak flow meter. They can assess the progression of the disease by daily doing by their own home. It will cost about 500-600 rupees.
So what about, sir, not that affordable thing, but what about lung transplantation in the future? Are we heading for something like that in at least a few centers in the country?
Yeah, it is one of the modality for the terminal IPF or fibrosis following COVID. So it is noted as one of the treatment modalities. So you have to think of that also.
Okay. And one more question, sir, which had come this is for Jabir, sir, giving anticoagulation in thromboembolism. How long would you like to prefer to prescribe anticoagulation for these patients?
Those patients in whom there is a proven thromboembolism, like a DVT or a pulmonary embolism, 3 months oral anticoagulation, just like any reversible cause, minimum of 3 months.
Okay, so yeah, basically most of the questions were on antifibrotic agents, and that has been explained by Venugopal so well anyway. And a few things about the treatment modalities, especially about selexipag and treprostinil. To Jabir sir, whether you would like to say something about these drugs and the usage?
What, Jimmy? I didn't hear it.
Selexipag.
I have not used selexipag. I have gone through the literature of selexipag. Selexipag seems to be a drug which can be used in the combination therapy, and there is some evidence which says that in a high-risk population we may use it early as a combination therapy, and this especially for us, we don't have a prostacyclin, so I think this is our prostacyclin we can use.
Exactly, sir, exactly. I think it was a long discussion, almost 90 minutes or more than 100 minutes up, right? Any last comments from Dr. Anil and Dr. Sajan? Want to?
Of course, this is a topic which has to be discussed because in the current scenario, we are going to have more and more patients with pulmonary artery hypertension as well as with idiopathic pulmonary fibrosis for the treating physician as well as the pulmonologist and cardiologist. More discussions are required in this field because we are still in the dark regarding the ultimate treatment of these patients.
Venugopal sir, any last comments? All of us are cardiologists here. You're the odd man, but you're the right man anyway to guide us to the future in pulmonary fibrosis and pulmonary hypertension.
So my ambition is that we will reach a position of the 1919 by 2013. So one more year is left for us to battle with this virus and study from this virus. We pulmonologists usually say that we studied much about the immunology by studying the tuberculosis. Now we are advanced we are studying much about all the immunological systems and the defensive system by studying the COVID viruses. So that is an opportunity for us, but it is a hard time for all, including doctors and nurses. So thank you all the doctors, Dr. Jimmy, Dr. Jabir, and Dr. Anil, and Dr. Sajan for the nice company. Thank you all.
Before we end, I think I'll request Ramanuja to MSN has to show some 2 slides more. Ramanuja, can you show your last slides and we'll just wind up?
Yeah, sure, sir. Yeah, at the outset, I would like to thank, I'm Ramanuja again. So at the outset, I would like to thank on behalf of MSN, so Dr. Jimmy Judge, sir, for chairing this session, and Dr. Jabir, sir, Dr. Venugopal, sir, Dr. Anil, sir, and Dr. Sajan, sir, for your enlightened lecture on PAH and fibrosis in especially COVID-19 patients. So thank you very much for your wonderful interactions. The session is very informative to most of the doctors across India. So once again, I would like to thank all our panelists, and not last but not least, I would also thank all our delegates across India for attending today's session in spite of your busy schedule. So I just wanted to show only one or two slides at the end. So I look forward for your exclusive patronage on world-class international quality brands. We have also launched this Favipiravir with the brand name Fabilo, 200, 400, 800 mg. And coming to our PAH range, we have got PAH, sildenafil citrate. Pulmonext is our brand of Ambrisentan. Mesitent, we have Mesitentan. Riociguard, we have Rioci 0.5, 1.5, and Bulbofip is our brand of Perfendone 267 800 per mg, and also 200 mg. So these are the drugs we have, and we are also shortly coming out with Selaxipac, this prostacyclin drug also, which we will inform once we get into the market. And so we may be the young player, but our drive and enthusiasm are very best in associating with you, sir. Thank you very much for joining with us. Thanks, sir.
Ramanuja, before winding up, I just I want to ask you one thing. Is your Riociguard right now available in Kerala?
Kerala, sir, we just started our Kerala operations from last month, sir. April onwards, we started our operations. But I have to check with my Kerala colleague, and we will get back to you maybe by tomorrow itself.
Please make it available at least in 1 or 2 places in a city. Second thing is, could you find out where exactly we can get this nitric oxide therapy, that is the pulse therapy of the nitric oxide?
Sure, sir.
And
sure,
please inform us. And third thing is, how can we get prostacyclin? For example, some affordable patient comes, they can be saved sometimes. At least we can add a year or two to their life when they become critically ill, to get them out of their critical illness. This prostacyclin may help. How to get hold on to this prostacyclin in case of an emergency? So these 3 things, please get back to us with an answer.
Sure, sir. Thank you so much. Definitely, sir. Thank you so much, doctors, once again for joining us.
Thank you.
Thank you.
Thank you. Good night.
Good night.
Everyone.
Take care. Stay safe.